Good morning. Welcome. It's my pleasure to welcome you to one of the best events that we have in our department every year, the Joseph Ignatius Lecture in Surgery. This lecture started out of a friendship between Dr. Tom Crummell and Dr. Ignatius. Dr. Ignatius is a native of Southern California. He went to Stanford University for undergraduate and medical school and then served in the Navy during the Korean War. Following that, he completed his general surgery residency under Emil Holman at Stanford when it was located in the city. After completing his residency, he started practice in Los Altos. And in the 70s, quickly became aware that the increasing knowledge and volume of surgical science that was being published was increasingly difficult to keep up with, and started something called the Surgical Index, where he summarized articles and their importance and made this available to surgeons practicing across the country. He was joined by his colleague, Dr. Bob Mitchell, in these endeavors and really kept this up for the following 20 years until it was taken over by the American College of Surgeons. And he will always be remembered for creating that surgical index. In addition to an amazing surgeon, he was a world-class tennis player and was ranked #1 in the men's tennis circle in California for several years running, and had championship wins over famous people like Bobby Riggs and Tom Brown. And I think it's really appropriate this morning to have Dr. Caprice Greenberg deliver the Joseph Ignatius Lecture, because her passion and enthusiasm for coaching surgeons to be their best athletes, I think, would really resonate with Dr. Ignatius. And I'd love now to introduce to you Dr. Caprice Greenberg. Caprice is a native of Chicago. She went to the University of Chicago for both undergrad and medical school, and then was recruited to the Brigham Hospital for her residency program. During that time, she got her master's in public health from Harvard School of Public Health, and then completed her surgical oncology fellowship at the Dana-Farber. She stayed on in Boston and was one of the inaugural leaders of their Health Services Research Center at the Brigham Hospital, and then was fortunate for the University of Wisconsin to be recruited there to run their Surgical Outcomes Research Center, and has done amazing things. She's an incredibly prolific publisher. It has garnered funding from multiple sources, including the NIH, the Agency for Healthcare Research and Quality, and Patient-Centered Outcome Research. And she presented some of her amazing data from that study yesterday to us. She has a breadth of research, both in health services, but as well as this area of physician coaching, which is in surgeon coaching, which is incredibly unique and novel, and I look forward to hearing about this. She's currently the Morgridge Endowed Chair in Health Services Research at the University of Wisconsin and Professor of Surgery. She's one of the immediate past presidents of the Association for Academic Surgery and one of the founding members and presidents of the Surgical Outcomes Club. And I can think of no better person here to have here this morning than Dr. Greenberg to deliver this lecture. Thank you, Caprice.
Great. Thank you so much for the opportunity to visit you all. Thanks to those of you who took time out from your busy schedule to come to dinner last night, and especially to the Ignatius family. I mean, what a tribute to Dr. Ignatius to have this lectureship and to have you here every year to really remember all of his great contributions to surgery. And I was just so excited to hear about his passion for tennis, because I really do think that what I'm going to talk about, how we can use coaching principles to improve performance throughout our surgical careers, will really resonate with what he was all about in his life and in his career. So thank you so much for the opportunity to serve as the 7th annual Joseph A. Ignatius Lecturer in Surgery. So I do have just one disclosure. We did have some funding from Covidian and Medtronic for some of the work I'm going to talk about, but other than that, most of what we've had has actually been federal funding to study the idea of surgical coaching. So my goal today is to really identify the gap that we're trying to address with surgical coaching, give you a definition, some theory and principles, talk about how we think surgical coaching can be operationalized, and then finally give you an update in terms of where we're at with the state of the science. So let's start with the gap. Why is there a need for surgical coaching? So most people in the room are familiar with this, but just to run through it, the way that we approach continuing medical education leaves something to be desired. The way that we've traditionally done this has been based on a summative evaluation. You complete your residency, complete your fellowship, you take a board exam, and poof, you're out there as a fully trained general surgeon, vascular surgeon, trauma surgeon. And we participate in CME, but the CME that we participate in isn't really based on adult learning principles. So what we do is very teacher-driven, right? So I've made a PowerPoint and you all are captive here for the next 45 minutes, and I'm going to tell you what I want to tell you, whether or not it applies to your practice or not. It's didactic and amassed, right? So again, everybody here is going to get the same information, and chances are everybody here are at very different points in their careers and have very different practices. We participate in M&M and then we recertify every 10 years, and I can tell you that I was so excited to get the announcement that the American Board of Surgery is looking at this to see if it's appropriate, because as a breast surgeon, I can tell you I haven't had a patient on a ventilator during my entire career, so it wasn't really a good use of my time to learn about critical care, because that's not part of what I do every day. So the goal, and people really recognize some of the limitations in our approach, has been to start moving towards something called continuous professional development. The idea here is that it's based on formative evaluations, right? So a summative evaluation is you pass or you fail. A formative evaluation tells you where your strengths are and where your areas for improvement are, and helps you think about how you could improve your individual performance. It's based on the concepts of lifelong learning, so it's student-driven. You as the student know what it is that you need to learn. You know your own practice. It's interactive. So it's conversation-based, it's one-on-one, and it's distributed. So it takes place in the places where we practice. It's based on learning how to do self-assessment and self-improvement. The goals are practice, modification, and improvement. And where the goal of our traditional approach to CME has been competency, the goal of continuous professional development is continuous improvement of performance throughout the life of your career. So in 2013, this really landmark study was published in the New England Journal of Medicine, and many people may be familiar with it. This came out of the Michigan Bariatric Surgical Collaborative, and what they did was they asked surgeons to send in a video of themselves doing sort of an average operation. Right? So everybody sends in their best operation, the one that went perfectly, and then they send that out to their colleagues, and everybody graded it using a modified OSATs. So basically they gave them a score on a Likert scale from 1 to 5 of how good they were technically as surgeons. So as you would expect, there was pretty wide variation, with people from about 2.5 up to about 4.5 in terms of how they were viewed by their colleagues. Now this was actually, in order to get this published in the New England Journal, they actually had to do a second evaluation where they had surgeons from outside the state come in and do the evaluation, and actually this range was even broader. So they really went kind of from 1 to 5. And just to orient you, a 1 is really where you should be when you finish training. So that's sort of where you are when you start your practice. A 3 is your average bariatric surgeon, and then a 5 is sort of perfection, what you think the ideal bariatric surgeon would look like. So this was great. I think all surgeons kind of know that there's a lot of variation in practice. I think the residents, know that there's variation in the surgeons that you work with in terms of their technical skill. But this was really the first time that somebody had quantified it for attending faculty. And this is really important because then you can use it as a measure or as an outcome in research. Perhaps the more important finding, however, is depicted on the next graph. Because this was done in their bariatric collaborative where they collect risk-adjusted outcomes, they were actually able to look at the relationship between an individual surgeon's technical performance and their complication rate. So if we look at that surgeon who had the lowest skill rating, their complication rate was almost 20%. And if we look at that surgeon who was the closest to 5, their complication rate is 4%. So that's a 5-fold difference in complication rate. So you can imagine if we can narrow this variation and improve everyone's performance, we can potentially have a really effective way to decrease complications and improve surgical outcomes. And this correlation coefficient was 0.8, which is a very strong correlation between two variables. So we started thinking about how could we improve performance. And at the time, I was in Boston working with Atul Gawande, and we had been doing a lot of work on system performance. So we had a lot of videos that we were using to look at teamwork and how the team interacted with the system. And we realized that we could use that for surgeon self-assessment, and that we could use coaching principles as a way to approach that. And so many people saw Atul's article that was in the New Yorker about this concept. And around the same time, we published the first academic article in JACS describing the proof of principle that surgeons were interested in and could benefit from video-based coaching. So what do I mean when I talk about coaching? As I go around the country talking about this, many people are like, look, you're just putting a fancy new name on something that we've been doing for a very long time. And I would argue actually that coaching is very, very different. And so let's start with a definition of coaching. Coaching is about unlocking a person's potential to maximize their own performance. It's helping them to learn rather than teaching them. It's about providing objective and constructive feedback to help someone recognize what works and what can be improved, and inspiring them to maximize their potential. So when you're a coach, you're in service of someone else's learning, but they have the responsibility for that learning. And that's very different than the way that we approach most of our education in surgery. So there's lots of different ways that you can break down coaching, lots of different types, but for our purposes, I want to just make the distinction between expert coaching and peer coaching. So expert coaching is when you use coaching principles to work with a resident or fellow, for example, somebody where you have knowledge that you're trying to impart to that other person, right? So there is by nature a hierarchy in this relationship with expert coaching. The other place that this comes into play is when an attending surgeon wants to learn a new procedure. And I'm going to talk a little bit about a study that we did trying to use these approaches to help surgeons who do open inguinal hernia repair adopt laparoscopic hernia repairs. But most of what I'm going to talk about this morning is related to peer coaching. And peer coaching is when two people who are at a similar level of knowledge engage in an equal non-competitive relationship. It involves the establishment of goals, the observation of a task, in our case it's an operation, self-evaluation and coach feedback to improve task performance and support change. So if you think about it, if you came in as an expert and tried to coach a surgical attending who'd been in practice for 10 years, that's probably not going to go so well. But if you come in as a peer in service of that person saying, I want to sit down and talk to you about the way that you do an operation and see if we can find ways to make it better, that's much more appealing. So let's talk for a second about adult experiential learning, because obviously there's a lot that's known about this. So in general, adults learn better when they're active participants in their learning. So the goal with adult experiential learning is really to support self-directed learning, to facilitate self-reflection, and to allow for the identification and pursuit of one's own goals. Now, keep in mind this idea that coaching teaches a new skill. It teaches you to have an accurate self-assessment because somebody else is there grounding you in reality. And it teaches you self-reflection, because I'm going to show you a study in a minute about residents that shows us whether or not coaching actually can do this. And the content has to be relevant. So it's related to current experiences and tailored to past experiences. So the way that you're going to coach somebody when they're in their first year of practice is very different than the way you're going to coach somebody who's in their 20th year of practice. But all of those people can benefit from coaching. And it's based on this concept of constructive feedback. And personally, I think constructive feedback is one of those terms in medicine that gets a lot of lip service, but that we haven't really figured out how to teach surgeons and other people in healthcare to give really constructive feedback. Most of what we give is not very constructive. It's good, you're doing a good job, great, keep going, or no, that's bad, let me show you how to do it. But there's never really concrete things that you can work on. So constructive feedback is descriptive and specific, it's non-judgmental, and it's focused on observations of behaviors and the impact of those behaviors rather than on assumptions or inferences. And very importantly, it's followed by an opportunity for the person receiving it to consider the feedback and respond, right? You can give feedback to someone, and then they can say that they don't agree with it, But then they have to actually make an argument for why they think that they should be doing things the way that they are, right? So constructive feedback, even if what you're seeing or observing isn't correct or doesn't resonate with the person, it sparks them to think a little bit deeper about why it is that they're doing something the way that they're doing it. So the goal with coaching really is to avoid something called the proficiency plateau. And this comes from Anders Ericsson's work. So he's worked with everyone from people in healthcare to chess players to athletes, and he's really interested in this idea of mastery. So what he says is that if we think about everyday skills, and for those of us that have toddlers, we know that when they first start to walk or to talk, right, that takes a lot of cognitive energy to focus on doing those tasks. But over time, it becomes autonomous and we stop thinking about it. The same thing can happen, he makes an argument in this article from Academic Medicine, that the same thing can happen with clinical medicine, where you start doing things on autopilot, right? You stop thinking about why you're doing them, you know that you get good outcomes, and so you stop trying to experiment and try new things and see if you can continue to improve. And really the goal of coaching is to try to transition clinicians, where many of us at some point in our career are on this plateau, back to continuous improvement. Expert performance. And many of you have probably read this book by Daniel Pink. If you haven't, it's really fascinating, called Drive. And he talks about the asymptotic curve of mastery. And it's this idea that in whatever you do, whatever performance you are pursuing, there's perfection and you're never going to get there. And as you move out along your experience curve, as you get better, the amount that you can improve gets incrementally smaller, but there's always more improvement to be made. Right? It's the same reason that Steph Curry continues to try to push himself in the ways that he takes his three-point shot. He's the best that there ever was at that, but he's continuing to try to push the envelope to try to improve in pursuit of that perfection. And it's the same idea for us in surgery. So one of the problems with this is that many of the concepts or the mental models that you need to transition into a coaching mind frame are in direct conflict with our surgical mental models and the ways that we approach life. So let's just take this concept of experts versus learners. So when we go into the operating room, we're experts, right? We have to be. Somebody's life is in our hands. The team is counting on us. We're the experts. So we know the answers. And because we know the answers, we can't really question what we're doing. So we rely on habits, routines, and rules. We feel competent, complete, and comfortable. And again, we have to do that when we're going into the OR. And this was one of the big things that Atul and I used to disagree about, because he really felt like coaching should take place in the operating room. And I really felt like it should be based on video and removed from the point of care. And I'm going to make an argument in a little bit for why I think that's important. But when you're trying to participate in a coaching program, both the coach and the coachee need to transition to a learner mindset. So you have to wonder about the answers and show great openness to the way that you traditionally do things. You have to be able to challenge assumptions and beliefs and continually test your competence and accept discomfort if you're going to try something new. And I think that can be very hard for us in surgery. The other issue is recognizing learner responsibility. And I think taking more of this in our approach to trainees is certainly a place where coaching principles can help. So often when we approach learning, especially with our trainees, we come in with a rescue mentality or a rescue mental model, right? We come in thinking that they can't do it without us. You fear they're not capable, and if something goes wrong, you're going to take the blame as the attending, right? That's the way the whole system is set up. And the problem is that this is very weakness focused, right? The person who is in the teaching position is the one who's making decisions and giving directions, and it's very results oriented. And what this does is it actually fosters dependence. So in the interaction between peer coaches, you really have to transition to one of responsibility, where you recognize that the other person has the wisdom and the ability to do something in the best way possible, and that it's your goal or your role and responsibility as the coach to bring that out. The other person has a choice about how to react and respond, and the other person needs to live with the results, right? You're trying to make changes in somebody else's practice. You can't dictate that as the coach, because you're going to go back to your own practice. You have to help that person figure out what it is that they need to do in order to improve. And this is very strength-based. Your role as a coach is to stimulate great thinking with great questions. It's learning-oriented and it builds capacity. If you do this right over time, people need less and less coaching because they learn to do self-assessment and self-improvement themselves. So how do we actually do this? That's the big question. So one of the great things about moving from Boston and Harvard, and I don't even know what their mascot is, to the University of Wisconsin is that there was amazing sports there. So I got to hang out with the Badgers, which was really cool. I spent some time with Brett Bielema before he left us, and Bo Ryan. Bo Ryan was named, Big Ten Coach of the Year many, many years in a row. He is a phenomenal coach. So we got to really sit down with these two and understand how they think about coaching. We also got to talk to some of their assistant coaches and then observe them in practice and try to identify what are some of the principles or things that we can learn from the way that they interact with their teams that we can use in surgery. We also spent some time at the music school learning how musicians and musical coaches coach, and then in education, which is probably the closest to what we're trying to do, where they have really integrated peer coaching into their professional development over the last decade. The other thing that we did was we did this enormous literature review of pretty much everything we could find from organizational psychology, coaching psychology, business, all sorts of different areas, trying to figure out, again, what are these principles that we see across all of these different disciplines that we can try to take and make into a conceptual framework that we can use in surgery to think about coaching. And so what came from that was what we're calling the Wisconsin framework. And this basically outlines the different things that you need to think about if you want to develop a coaching program. So the first thing you have to think about is the coaching context. So is it going to be video versus live, peer versus expert, institutional versus regional versus national? And I've been involved in coaching at all of these different levels. In the green are the things that you want to be aware of, but that you don't want to control for. So you want this to work for every surgeon, regardless of their experience level, regardless of their practice setting, and any operative context, so whether they're in private practice or academics. You need to, again, be aware of these things and think about, can somebody in academics coach somebody in private practice, or should you match people based on their practice settings? The blue are things that you can control for, right? So how are you going to identify the right coaches that have the right knowledge and experience? Because not everybody's cut out to be a coach. And most importantly, the interpersonal skills, right? So how are we going to find the people that have the right communication skills, the right interpersonal skills? And then in the middle here is what really happens during the coaching sessions. So coaching is really based on relationship building, goal setting, using inquiry and constructive feedback, and action planning. And so we developed a coaching training program which teaches surgeons these 4 sort of basic competencies that you need to be an effective coach. And then the focus of coaching. So this was based on the literature that's out there on what are the different components of surgical skill. A lot of this comes from Steve Ewell and Rona Flynn and the group at Aberdeen. But it's this idea that there's technical skills, right? So there's your psychomotor, there's your exposure, there's your approach, there's sort of the technical aspects of the case. Then there's the cognitive skills, so your decision making, your judgment, your situation awareness. And then there's your non-technical skills or your interpersonal skills, communication, leadership, and teamwork. And the reason I have these blue arrows up there is because it is impossible to differentiate these and really take them independent of each other. But what this does is it gives you a framework or little buckets that you can think about in order to get our heads around what people are discussing. But there's no way that you can talk about somebody's exposure or approach without talking about their judgment and their situation awareness. So these are all really interrelated. One of the things that we didn't recognize but came out as we started doing these coaching sessions with surgeons is the incredibly important role of stress management. And this has actually started to emerge in a couple other papers that have come out since I started doing this work. But it's this idea that people can get into trouble in the OR when they can't recognize their own stress level, when they don't have the skills to communicate to the team when the case is starting to go south until they're really in trouble, and then they blow their top. And then they get labeled as a disruptive physician. And so we've had several people who've gone through the coaching program with the idea that we want to teach them sort of the warning signs that things aren't going the way that they should, and give them some language around engaging the rest of the team to help them to recognize, let's turn down the radio, let's stop talking about the weekend, let's get ready to open or convert, right? And that's not something that, again, people are necessarily good at. So I already mentioned the activities of coaching. The most important is active listening. This is really critical to develop trust, rapport, and develop powerful questions. People in general are bad at this. I would say that surgeons are probably worse than the average person at this. So I would challenge each of you today, pay attention when you're in a conversation to how much time you spend actually listening to understand the point of view of the person you're talking to versus waiting for your turn to talk. And when you're listening to that person, many times we're thinking about how we're going to advocate for our position, we're thinking about what it is that we're going to say, and we're not necessarily purely listening to understand someone else. So just think about that. But in general, Americans spend about 80% of their time advocating for their position and only about 20% of the time listening. Powerful inquiry. How do we use open-ended questions to challenge in a non-competitive, non-threatening manner? And then constructive feedback, which we've already talked about. So who makes an effective coach? So this is pretty clear. The most important thing in being an effective coach is communication skills and adaptability. So I remember when I was talking to Bo Ryan, he really illustrated this for me. He said, you know, there's guys on the team where I can get in their face and I can yell and I can swear and they're really going to respond to that and they're going to step it up. There's other guys on the team that if I did that, they'd be in a puddle on the floor. Those are the guys that I have to put my arm around and talk to in a soothing voice when we're walking in the locker room at halftime. And that's what they respond to. And a good coach is able to read the person that they're working with and adapt their style to what it is that that person needs in order to be able to respond. And to do that, they have to be able to assess and understand the coachee's needs and their perspective. They have to be able to motivate. They have to have a broad knowledge base, and they have to be respected. You know, again, we have surgeons out there that everybody talks about as hacks, right? Nobody in this room is that person, but we've heard that term and we know that. Those people can't be coaches because surgeons aren't going to respect them. You don't have to be the master surgeon, the guy that people go to when they're in trouble, because there's probably only one or two of them. But you have to be respected as somebody who had solid surgical skills in order to be a coach, and you have to be a surgeon. So video versus real time. So I think video is much better than trying to coach in real time for a variety of reasons. So the first is that it allows you to view your own performance. We have very few settings where we watch ourselves operate, and it is incredibly enlightening to watch yourself. It's more successful in sustaining behavior change. That's been proven in a number of different disciplines in their literature. It confers a time savings of 50 to 80%. The biggest issue that we have with coaching is figuring out how the heck to find the time to do it. So the idea that somebody's going to take a day off and go and sit in the OR where somebody does a 4 or 6 hour Whipple, that's just not realistic. With video, you can set the time for how long people take. So we basically limit our video sessions to an hour. You have an hour. You can fast forward, you can rewind, you can go to any of the salient points. Most people are done between 30 and 45 minutes with this. It removes concurrent responsibilities to allow full concentration on performance assessment. There is just no way if somebody's trying to coach you in the OR that you can really concentrate on what they're telling you if you have a patient on the table. And then it mitigates medical, legal, and credentialing complexities, right? Because if something goes wrong and you're there as a coach, what is your responsibility to the patient? Whereas if you're doing this retrospectively, I've talked to lots and lots of lawyers and compliance people, and really this falls under peer review. So video capture in the OR. It's not perfect. It's getting better. We're getting there. But it's amazing what you can do with GoPros and different cameras. For a while, we were using these extreme sport goggles, which have a little camera, a little microphone. They cost about $150, and you can really capture an operation pretty well. And then most ORs have inlight cameras, wall cameras, different ways that you can capture what's happening in the operating room. So timing, this was something that we also talked to all the different discipline coaches about. So immediate versus delayed, right? Should you walk out of the OR and get into the next room and have your coach waiting there to look at your video? Probably not. So this came from music. They said if you watch your video the next day, it's very different than if you watch it right after. Because if you watch it right after, you remember exactly what you were doing and why you were doing it, and you miss a lot. You're making a direct map of what you do. So they say to wait a week. So our goal is really somewhere between 1 and 3 weeks for people to review your video so you remember the case enough to know the specifics, but you don't remember exact things about the case. And it's amazing when people do that, right? Because they walk and they say, oh, the case went fine. And they watch the video, they're like, wow, I'm kind of dicking around. I'm not really making much progress there. What's happening? And so the idea, and there's literature to support the fact that task-specific feedback should be immediate, right? So if you want your residents to throw a stitch differently, you need to tell them right away. But if you're talking about more complicated feedback that really gets at how you approach surgery, it's better in a delayed fashion. So, state of the science. Is there any evidence for what I'm talking to you guys about? And there is. It's emerging. It's slowly coming around. And, I actually got into a little bit of a debate at American Surgical, which probably wasn't the best idea as a new initiate. But we were talking about surgical coaching and different approaches to continuous professional development. And people were like, yeah, but doesn't impact outcomes. And, my point was, we have no evidence for what we do now, so why would we hold this to a higher standard? So as we go through this, just think about, that fact, and think about what kind of evidence you would want before you would accept coaching as a way to approach continuing professional development. So let's start with the students. Most educational research starts with the students, right? They're easy targets. They have more time than most of us. So this comes from England, where they basically randomize students to either access to a simulator to learn laparoscopic skills with sort of the usual curriculum, or a video-based review with an expert. And as you can see, there was significant improvement in the students that participated in the video-based coaching. And those that just did our usual approach, there wasn't much improvement over the course of the study. So more evidence that sort of our current approach to education might not be the best, and that video-based approaches can help. The next study comes from Canada, and this is residents who were on a minimally invasive surgery rotation doing bariatric surgery. And they, again, randomized people to either video-based coaching or the control group that went through the way that those of you who are residents are going through probably your rotation today. And what they did was they scored them on OSATs. Again, this is a measure of technical skill, a bariatric specific OSATs, and then they also looked at technical errors that they made in the operating room. And as you can see, at baseline, there was no statistically significant difference between the two groups, so the randomization worked. And at the beginning and end of the rotation, unfortunately, there was no statistically significant improvement in performance for those who went through the way that we currently do our training. Now, for those that were randomized, however, to the video-based coaching, you can see that there was a statistically significant improvement in all of the measures of their surgical performance. So suggesting, again, that video-based coaching can actually improve performance. But again, in my mind, the more important part of this was the self-reflection. So remember, I told you that the goal of coaching is to teach people to have a more accurate self-assessment. And at baseline and at the end of the study, there was no statistically significant correlation. So there was no correlation between the way that the individual residents graded themselves on a Likert scale from 1 to 5 in terms of their technical performance, and the way that a panel of experts graded their performance. No correlation. And in fact, if we look here, there was actually a negative correlation. So the better that they thought they were, the worse they actually were. And there's more data to show that this in general is true of surgeons. We really aren't very good at assessing our own technical skill. However, after participating in surgical coaching, we can see that there was actually a correlation coefficient of 0.8 and 0.85 in how the residents viewed or graded their technical performance and how they were graded by the experts. Again, showing that there was some insight that they got into how they were doing from a technical standpoint. Again, really important. So in the same edition of Annals of Surgery where that paper came out and I was all excited, I then turned the page and turned to this qualitative study that also came out of Canada that said that basically surgeons in practice had no interest in coaching and it was never going to work. So that was a little disappointing for me, but luckily I had been asked to write an editorial on that with Mary Klingensmith, who's the current director of the American Board of Surgery, and we wrote an article that basically said that the reason surgeons said that they wouldn't do coaching is because they didn't understand what it was. So if you look at the different arguments they had for why they didn't want to do it, one, sort of the value of technical skill, this idea that surgeons in academic practice feel that they have sufficient technical skills, and now they want to work on other things. So they want to work on their leadership skills, or they want to work on how they are as an educator. And so we made the argument that actually coaching can be very effective in all of those different areas. So you can use coaching principles to improve your leadership skills or to improve the way that you are as an educator. And in fact, in the operating room, many of our academic surgeons, what they want to focus on is how they better take a resident through a case, right? Because that's most of what they should be doing. There were concerns about image and authority, right? So the appearance of competence and expertise, and this idea that if you have a coach, there's something wrong with you. And so again, our idea of removing coaching from a clinical setting and having it be a confidential session with another surgeon, and the fact that really our goal is to do this in a non-punitive setting. And I will tell you, the people that have participated in our coaching sessions, the people who want to be coached, are in some ways the people who have the highest levels of self-awareness and often are the best because they want to continually improve. And then finally, this loss of autonomy, that surgeons desire to maintain control over their learning agenda. And I would say that right now, if surgeons think we have control over our learning agenda, we're kind of fooling ourselves because we really, right, it's CSAP, it's CME, it's, these things that we don't really control. Whereas if we were sitting down with a coach to improve our practice and that coach was helping us to figure out what we needed to learn, that's control over your agenda. All right, so peer coaching, this is what we want to do. So the first program that we did this was in Wisconsin, and we partnered with our state chapter of the ACS in order to do this. And there was some literature that this was based on from pediatrics where they suggested that regional and state organizations are a good place to have QI initiatives because there's trust, familiarity, and participation. Physicians from across practice settings are engaged, right? If we did this at the AAS and SUS, there would be no community surgeons that would participate. And then they're small enough to afford some familiarity with and respect for the coach. Our coaching program was a quality improvement initiative. What we did was we actually asked for peer nominations, and this was a really effective way to find people who had the right communication skills and interpersonal skills. So there was no self-nomination. You had to be nominated by somebody else. But we put out what the good qualities of a coach were, and we got some phenomenal coaches. We put them through a 4-hour training program, developed a resource manual. Our goal was to recruit 10 surgeons to participate, where they would record an operation based on individual goals, participate in this 1-hour coaching session, and then repeat this 4 times throughout the year. These are our resource manuals, and I just want to show you a couple of short clips in terms of what a coaching session actually looks like.
So you got through that initial difficult portion, and you were talking about another area that you kind of struggled in terms of progressing. You want to fast forward to what you're talking about there?
So here the residents are all pretty good at isolating the cord structures, and so there's not much to see here. So if we fast forward to really, I think the next part that I tend to struggle with is the actual mesh placement itself. And so, I've never really loved the Wheatlanters. I think they tend to just be more in the way, and the ones that we had where I trained never really held all that well, and so I've never been a big fan of using them. But so at the same time, then I usually end up sacrificing one hand to try and hold things open while I'm trying to follow with their suture on the mesh and then trying to hold the mesh in place. And so I've had all these different things I'm trying to do, and I just feel like I end up with a finger in the surgical field holding the mesh down and another hand doing something that's probably not ideal.
Sure. And there's a bit of stuff in there, too.
So that was a surgeon who was a minimally invasive surgeon who did, 90% of his hernias laparoscopically. And when he did them open, there was a reason he was doing them open, right? So it was a complex patient. It was a redo. The patient had had, previous surgery. Something was going to make it more difficult. And so he chose to do open hernias as his case that he wanted to review with his coach. And I'll tell you, the people that get the most out of these, the most valuable coaching session I saw was somebody who brought a case where they were taking out a major sarcoma and they got into massive bleeding from the iliacs. And there was so much that surgeon learned, all the way from his incision placement to how he was retracting to how he approached the tumor from which side, that he came back and said, he really changed his approach to how he was taking these things out by watching the video with the coach and going back, knowing what happened, and then going back and looking at the decisions that he had made that got him to that point. So it takes a very confident surgeon to be able to bring in a case that doesn't go well and ask for help. So this is just a quick video to talk about how you can also address interpersonal skills.
So far, most of our discussion is focused on the technical aspects and the kind of cognitive approach to these cases. Let's talk a little bit about your interpersonal skills and how they relate in the operating room. How do you feel like you get along with folks?
I think I'm a pretty easygoing guy and tend to get along with most people in the OR.
So you walk into the OR, tell me what kind of things you do.
So usually I just go and help the nurses and start prepping the patient.
Okay. They appreciate that, I assume.
I think so. I hope so.
So maybe we can start by looking at the beginning of your case,
Yeah, sure.
when you first walk into the room. Stop it there for a second. Your thoughts.
It does look like kind of everyone else in the room maybe tensed up a little bit, which I don't think I've ever really noticed before.
And do you think it's something from the past, or is it something going on that day?
No, I mean, I think, when getting to the OR and usually cases start late, I maybe get a little frustrated and just try and move things along to try and get back on time, and maybe that's kind of a weird environment for everyone.
Okay. And I think that's an important thing to look at, too, because, clearly the team is...
So again, we don't necessarily have the time to process how the way that we act is impacting the other people in the room. But watching it on video, you can really see how you set the tone in your OR. And some other work that I did with one of my residents, we found that everybody agrees, from anesthesia, nursing, surgery, that it's the surgeon who sets the tone for an operation. And so understanding how your interpersonal skills impact the way that a case goes for everybody is really important. So with this coaching program, we have a lot of perception data. That's basically what we were able to get because we couldn't link this to clinical outcomes. So the first thing is, why did people participate? And there's this expectation to learn, but the most important resounding thing that kept coming out was this responsibility to maintain and improve my skills as a surgeon. The community surgeons, we're a very rural state, and the rural community surgeons are the ones who are the most enthusiastic about this. I had one guy who said, if you tell me that there's a coaching program and I don't participate in it, I don't know how I could look my patient in the eye and say that I've done everything I could to be the best surgeon I could be. People feel responsibility and they want to be their best. So in general, the coaches perceived, all of these are on a scale from 1 to 5, with 5 being completely agree, 1 being completely disagree. So in general, coaches perceived that they were prepared to act as a coach. They were actually graded even better by the people that they were coaching in terms of their performance. I thought this one was particularly important, that they made valuable suggestions for alternative approaches, techniques, and solutions to try out and practice, a 4.6 on a scale of 1 to 5. And then the program evaluation. Again, I think that the fact that people rated this, I found my coaching sessions to be valuable, 4.6, and I was satisfied with my experience, 4.4. So when I went back to Wisconsin Surgical and I presented this, I had 4 different surgeons who stood up, and I swear they weren't plants, and said, I participated in this program and I changed something about my practice that I still maintain today. It brought tears to my eyes. I was like, oh, it's actually working. So the deliverables, our goal was really to develop a coach training program, to do preliminary work for a randomized controlled trial. And then the other thing I didn't have time to go into is that we developed a rubric to evaluate the quality of the coaching. Because if somebody works, this is basically fidelity of the intervention. If somebody participates in an intervention, the intervention actually isn't working, that's not really participating in the intervention. So our challenges were related primarily to scheduling. This was designed to include 4 longitudinal sessions. We didn't have a single participant who could do this the way that we designed the Wisconsin program. And that is because we didn't want anybody from the same hospital or the same market coaching each other. So people were driving across the state to do this, and getting people to do that just wasn't working. And then the technical approach for video review was limited, but again, this is getting better. So our solutions, we think that this needs to be integrated into existing quality initiatives and surgical societies. There needs to be experimental tests of the optimal timing and formats. And the video review, for now, we're limiting it to laparoscopic technical capture and partnering with industry to see if we can come up with better solutions. But really, the surgical societies and the different regional collaboratives are taking ownership of this, and we have exciting work going on with a variety of different surgical societies and quality initiatives. Just briefly, one that I'm particularly proud of, so Justin Dimmick and I co-PI an R01 from NIDDK to look at applying our coaching program to the John Berkmeyer study that I showed you from the New England Journal. Basically, we, interestingly, the surgeons in Michigan, no matter how many times I told them that the best coaches, it was all about interpersonal skills, they said, I don't want to be coached by anybody who's below me on this scale. And so we basically had to take the top quartile and teach them coaching skills. And I'll tell you, one of the great things about doing it this way is there's way more variety in how good the surgeons are at coaching in this than there was in Wisconsin. So this is a step wedge design where everybody participates, even the coaches. All of the coaches, they're probably our most enthusiastic coaches, actually, because they really understand the concepts. So we set out and we were funded to have 30 participants. We actually ended up with 45 participants. They were supposed to do 4 longitudinal sessions. Many people are on their 7th session and they don't want to stop. So it's going to be integrated into what they do. Now, why was this so successful compared to Wisconsin? First of all, it's a limited clinical focus, right? So it's just bariatric surgery, whereas in Wisconsin we were doing surgery very widely. It's a laparoscopic procedure, so it's easy to capture. We added it onto an existing meeting. They already got together 3 times a year, so they just came an hour early to review their videos. The surgeons who were already engaged in that quality initiative were the ones that were targeted for participation. And they already had a culture of trust, right? They already had sent out their videos to each other. So they'd been working together on quality for over 10 years. So they trusted each other and had the relationships to do this. I think in the interest of time, I'm going to skip over Project Adopt, but this is the project that I told you about where we tried to teach surgeons who were doing open inguinal hernia repairs and also did lap appies and lap choles to do laparoscopic cholecystectomies. But basically the way that this worked was that we took 3 existing programs at the University of Wisconsin. The first thing we did was have them go through a simulation. Then we had them actually come and scrub with an expert at the University of Wisconsin and act as an assistant. That surgeon then went out and was a preceptor and was present the first day they did it in their practice. And then they transitioned to coaching, where they recorded their first 10 to 20 videos of their procedures and reviewed them with their coach so that they could make sure that they were doing things correctly. And basically, when the coach and the coachee were both comfortable with performance, then they graduated from the program. So my closing comments. I think that surgical coaching has the potential to improve performance throughout our careers. It incorporates concepts of adult learning theory and coaching principles of co-learning. It's based on self-assessment and individually goal-oriented and facilitates transfer into practice. It offers novel opportunities for performance improvement in cases we already do, as well as a really structured approach to learning new procedures, something that we have a ways to go on. It can allow us to address variation in performance and improve quality, safety, and outcomes, but the biggest thing is that this requires a cultural change. So if we think about traditional surgery, our guiding principle is autonomy. And what we need to move towards is something that's more based on collaboration. Our learning is amassed, and we need to move to individualized learning. Our evaluations are summative, and we need to move to formative. And our goals in the past have been competency, and we really need to move towards mastery. So with that, I'd like to acknowledge my colleagues who have worked on this. Obviously, this is the work of a lot of people. And thank you for your attention. I'm happy to take any questions.